the exciting aspect of what's going to happen in immunotherapy, I mean, first there's the combination immunotherapy agents, which we've seen in melanoma is much better with a PD-1 inhibitor plus a CTLA-4 inhibitor. So those type of drugs. In fact, we're participating in a study now where patients are randomized to chemotherapy, a PD-1 inhibitor, and a combination PD-1 CTLA-4 inhibitor. So those are some of the questions that need to be answered. I think the other interesting area is really the neoadjuvant or adjuvant space. As you may know, there's been a number of, well, as most people know in our field, that there's been two prospective randomized trials of patients with muscle-invasive bladder cancer receiving chemotherapy, and that translates into a survival advantage. But it's not without toxicity and even mortality, in patients receiving chemotherapy. If immunotherapy will be doing the same thing, or if you select patients that can get neoadjuvant immunotherapy, downstage them, or perhaps it's surgery even with muscle-invasive disease and post-operative immunotherapy, I think that'll be a step forward. Again, effective therapy is less toxic. And then the other space is superficial bladder cancer. And is there going to be a role for, we know BCG is an immunotherapy, and you put it into the bladder and it works, but most patients, or many patients, relapse. So will we be able to use some of these checkpoint inhibitors and other immunotherapy agents to treat really early stage bladder cancer? So the good thing is urothelial cancer is a drug that's responding to immunotherapies. I think it's probably, looks like right now it's the biggest, may be the solid tumor outside of melanoma that has the most benefit to patients. So it's really a new era.